Turning back the tide. After my April Fool's wake-up call, something else happened that had a further impact on my commitment to antibiotic stewardship. I began working at Glencroft, a large long-term care campus in Arizona. My mission? To help them implement an effective stewardship program. Indeed, my time at Glencroft planted the seeds for the program I'm going to share with you in this audiobook. It was in its nascent stages, though. I knew what we needed to do. Stop giving antibiotics for infections people didn't have, but I wasn't sure exactly how to go about doing that. Luckily, I had someone who proved to be a valuable ally, a woman named Mary Patterson. Mary was the Assistant Director of Nursing, ADON, at Glencroft. No nonsense and direct, she immediately understood the problem when I explained the patterns of increasing resistance I had seen. One day she called me on the phone. "Dr. Pede, I don't know why we have all these urinary tract infections. Something's going on here." I reviewed the data and then met with her. She was exactly right. Something was going on. The so-called urinary tract infections weren't infections at all. They didn't fulfill a complete case definition as defined by the McGeer criteria for urinary tract infection surveillance. To put it more succinctly, these weren't UTIs at all. Instead, they were the much more common asymptomatic bacteriuria, ASB. Once Mary understood what was happening, she sprang into action. Anytime someone ordered a urine culture, she would confront them. "Why did you order that urine culture? Tell me exactly what was going on with that patient that caused you to make that decision." And let me tell you, the response, "because that patient was confused," or "their urine was dark, foul, stinky," wasn't good enough for her. Pretty soon, because of her efforts, the number of urine cultures began to go down. And not long after that, antibiotic resistance began to drop. A table illustrating the 180-bed SNF stewardship results from 2015 is available on my website. In this table, you will see that the C. difficile positive and ESBL positive results dropped to 0 and 4 respectively. Case definitions matter. The situation in Glencroft wasn't unique. Most cases of presumed UTI are actually ASB. By definition, ASB is when bacteria are present in the urine at levels often regarded as clinically significant, up to greater than 100,000 colonies per milliliter, but, crucially, the patient exhibits no or minimal symptoms related to the urinary tract. As you now know, and as Mary found out that day, a significant proportion of antibiotic prescriptions for UTIs are driven by the misinterpretation of ASB as a treatable infection. It's not. And giving antibiotics to treat ASB does nothing except increase resistance to those drugs. There are several common ways that ASB can masquerade as an infection. It may show up as a positive culture, which then leads to the diagnosis of UTI and a resulting antibiotic prescription. This is especially common in patients with altered mental status when they have a positive urinalysis/culture and sensitivity, UA/C&S. Or a positive UA/C&S may seem to predict the risk of invasive infection. While potentially concerning, none of these fit the case definition of a UTI. Positive urine culture. At least 100,000 colony-forming units, CFUs, per milliliter of one organism. Positive UTI clinical picture. At least one of the following. New acute dysuria. Fever or leukocytosis and one of the following. Acute flank pain or tenderness, bladder pain or tenderness, hematuria, visible blood in the urine, new or marked increase in incontinence/urgency/frequency. If absence of fever or leukocytosis, then 2 or more of the 4 items just mentioned.